So the Socrative, the code is OSME, as always. I'll just put it in the chat as well. Um, we'll start the Socrative probably after each of the sections. We'll do RESP first and then move on to immunology. Okay. So starting with RESP, your syllabus covers lung tumors, which we'll start with, then looking at chronic airway disease. And we'll move on to the vascular disease, so especially ARDS, PE and DVT, and then touching on the causes of pulmonary edema and the types of pleural fluid. And after that, we'll go on to resp infection, so splitting this into upper resp infection and lower respiratory tract, and finally, mycobacterial infection. Okay, so we're going to start with lung tumors. This is quite a high yield topic, and they like to bring up histology slides and the paraneoplastic syndromes, particularly in LabMed. In terms of general characteristics, lung tumors are a pretty common cause of death in the developed world. And smoking is by far the biggest risk factor. But other risk factors to look out for in the history, so in the question stem, are things like breast tumors, like solid tumors, or things like Hodgkin's lymphoma, where the patient would have prior radiation to the chest. And also looking at occupational hazards, so asbestos. For asbestos exposure in the history, you're going to have occupational exposure, so things like working in shipyards or working in with old machinery, so sort of pre-1980s, working in factories, things like that. In terms of the presentation, so systemic symptoms are going to be similar to any other malignancy, so weight loss, fever, night sweats. Um, and then specific to lung malignancy, local symptoms will include things like hemoptysis, if a tumor invades into the pulmonary vasculature, cough and dyspnea. And there are also an increased risk of obstructive pneumonia, which can then be complicated by abscess formation. And we'll touch on that later as well. In terms of where primary lung tumors would metastasize to, these are in order of like how common they are. So the liver, adrenals, bone, and brain. On that point, though, if you have a lung tumor, it's more likely, sorry, multiple tumors in the lungs, things like cannonball lesions, those are more likely to be metastasis from another tumor. And tumors from basically anywhere in the body can metastasize to the lungs via the vasculature, so hematogenous spread. We'll touch on the paraneoplastic syndromes when we come to each of the specific tumors. And then finally, in terms of general presentation, things like your increased risk of thrombosis, so DVT, which can lead to pulmonary embolism and anemia, especially if it's a long-standing tumor that hasn't been picked up, you'd have anemia of chronic disease, so a normocytic picture. Okay, and then if it's a particularly aggressive lung tumor, primary lung tumor, you can have local invasion, and so they might describe some of these symptoms, either in the context of so asking you what structure is being obstructed, or they could just give you these in the question stem. And ask you to sort of pick between a central tumor versus a peripheral tumor. And so some of these will be more likely to be caused by central tumors obstructing, like the hilar region. Yeah. And we'll talk about which tumors are central and peripheral in a second. Um, so some of the symptoms include hoarseness. This is impingement of the recurrent laryngeal nerve. Dyspnea and shoulder pain can happen by phrenic nerve impingement. On the phrenic, sorry, when talking about phrenic nerve, you can also, they could give you a chest x-ray and show that there's paralysis of the hemidiaphragm. So half of that would remain sort of dome shaped, and that's ipsilateral, obviously. You can get dysphagia if the esophagus is obstructed. And then thinking about the apical lung tumors, we can have Horner syndrome. This is a sympathetic chain dysfunction and will lead to ipsilateral meiosis, anhidrosis, ptosis, the normal triad. Other things that can happen in an apical tumor are, again, shoulder pain, paresthesias down the arm, and atrophy of the intrinsic muscles of the hand. And this isn't to do with the sympathetic chain, but rather brachial plexus impingement. Um, Finally, so I was mentioning differentiating between central and peripheral lung tumors. The central tumors are more likely to be the ones that cause things like superior vena cava syndrome. So if a person presents with facial flushing, unilateral extremity swelling, so like a edema-esque picture, or distended head and neck veins, that's probably obstruction of the superior vena cava. Um, when you do your respiratory exams on patients, they might describe or you might observe a positive Pemberton sign, which is where you ask the patient to raise both arms above the head for 1 minute, and then you'll see them go very plethoric and they might become more short of breath. Um, just before I move on, so if they give you a chest X-ray and you see a coin lesion, so a lung tumor should be on your differential, but some of the other differentials to think about are granulomas. So we'll talk about the different causes and different types, caseating versus caseating, etc. Um, and hamartomas, which are sort of proliferation of normal tissue. So it's benign, but if they don't present with these systemic symptoms, then that's also something to consider. Okay. Um, Moving on to the different types of lung cancer. So we'll categorize these into non-small cell lung cancer. And here the most common one is an adenocarcinoma. And the other two important ones that we'll discuss are squamous cell carcinomas and large cell carcinomas. And then obviously the small cell lung carcinomas, which are less common but more aggressive. When we go through the size, we'll talk through which are peripheral and which are more likely to be central. Okay, so we'll start with the small cell lung cancer. Um, you can see this histology slide here. They could either give you this slide or they could describe in the question stem small blue cells of neuroendocrine origin. And these are Kulczycki cells. They're found lining the resp and gastrointestinal tract. Other things that they might note in the question on histology are lymphovascular invasion. As I mentioned, it's a highly aggressive tumor, so it's more likely to go into the lymphatics and the blood vessels. And so is also these people will present with hemoptysis. Um, they'll be positive for markers for neuroendocrine cells, so things like chromogranin A, synaptophysin. They're not so high yield for LabMed, it's more the histology. And the paraneoplastic syndromes. And here you can remember these as the three A's, so ACTH, ADH, and antibodies. ACTH, so if a patient presents with hemoptysis, night sweats, but also with abdominal striae, neck hump, osteoporosis, then you should be thinking about excess cortisol. The other key links, so they can link here to your endocrine and biochem things and ask you about, how do you test for Cushing's syndrome and how do you differentiate from Cushing's disease? So whether it's a pituitary origin for this excess ACTH or if it's somewhere else. And here, when you do that high dose dexamethasone test, your cortisol won't be suppressed, whereas with a pituitary tumor, you would. Is that okay? Okay, and then ADH presenting with hyponatremia. So if they give you the bloods, or they can just say the patient presents with confusion, seizures. And finally, Lambert-Eaton syndrome. So the antibodies here are against the presynaptic voltage-gated calcium channels. So the mechanism is that the acetylcholine in the vesicles can't be exocytosed, and that's why you get the neuromuscular weakness. They could ask you to, differentiate between this and myasthenia gravis, so you should just know where the antibodies are directed in MG, which is against the acetylcholine receptor on the muscle itself. And then in terms of presentation, sorry, in terms of presentation, this is also a proximal muscle weakness, and they'll get hyporeflexia, but this muscle weakness improves with activity. rather than myasthenia gravis, which gets worse over the day or with activity. This is the first of our central tumors, so this is more likely to be in the hilar region, if they show you a chest X-ray. And then the other one that's more likely to be central is the squamous cell cancer. Here, the histology is again really important. They'll show keratin pearls, which you can, I don't know if you can see my cursor, but this first picture at the top. Um, Keratinization, and if they show you a picture that's more zoomed in, you'll see intercellular bridges, or they can call them desmosomes in the question. Um, these are also associated with cigarette smoking. The smoke sort of damages the respiratory epithelium, and so it'll set off this metaplasia dysplasia sequence, which results in carcinoma. Again, this is a really important paraneoplastic syndrome. These tumors secrete parathyroid hormone-related peptide. Again, they can link this to your endocrine biochem um, and show you lab results. So here you'll have increased calcium, reduced phosphate, and it's important to remember this PTH-related peptide is not the same as endogenous PTH. So PTH will be low because the body will, or the parathyroid gland will sense that there's high calcium. Um, Great. And then moving on to large cell carcinoma. This is maybe the lowest yield lung tumor for LabMed. Um, the only thing they could say in the question stem is that it's undifferentiated, or they can show you this histology slide where you can see these giant cells with multiple nuclei. These are more likely to be peripheral tumors. Um, and in terms of paraneoplastic syndrome, again, it's not super high yield, but sometimes they can produce beta HCG, and in a man, this would present as gynecomastia, so benign enlargement of breast tissue. Okay, and then finally, last actual lung tumor, adenocarcinoma is the most common, as I mentioned before, accounting for 40% of cancers. Here, this histology slide is super high yield. You can see these glands forming, but in a malignant way, so lots of them. Um, in terms of staining, these cells will stain positive for mucin, some adenocarcinomas. Um, and then here, I think, as per your syllabus, the important things are to remember the mutations that can drive these cancers. There are four that you need to remember. So EGFR, KRAS, ALK, and PDL1. Yeah, I mean, you can learn this isn't as important, but EGFR and ALK mutations are the ones that are most commonly seen in people who don't smoke, and KRAS more commonly seen in smokers. Having said that, I think when they present these tumors on question stems, adenocarcinoma should be associated in your head with people who don't smoke, so young women, non-smokers. Um, and the fact that they're peripheral tumors is also really important because, as I said, the large cell carcinomas don't come up as often. You can also, well, you do the molecular testing to inform your treatment. For EGFR mutation positive tumors, you can give tyrosine kinase inhibitors. The same for ROS1, you can give tyrosine kinase inhibitors. And for ALK, you would give an ALK inhibitor. I mentioned there were four mutations, so they can also check for PDL1 expression. PDL1 can be upregulated by the tumor to suppress normal T cell activation. And so there are monoclonal antibody inhibitors of PD1 that can be given as well. Okay, so that's all of the actual lung tumors, but we should finish with mesothelioma, a malignant tumor of obviously mesothelial cells. Here, the histology finding that's key are samoma bodies. You can see these swirly things. You'll see these in some other cancers as well. When I do the neuro session, we'll talk about CNS tumors that have these, and some of the repro tumors as well. In the history, you'll almost always find that they've had asbestos exposure, but the LabMed lecturers and question setters seem to love the fact that if someone's been exposed to asbestos, their risk of bronchogenic carcinoma is actually much higher than their risk of mesothelioma. But if someone has a mesothelioma, then it's likely that they've been exposed to asbestos, if that makes sense. They might also note other signs of asbestosis. So they can say pleural thickening, or they can show you the histology of the ferruginous bodies. We'll talk about this in more detail when we do the chronic lung disease section. And in terms of presentation, again, these are pretty aggressive tumors. They'll present with the same B symptoms, fever, night sweats, weight loss, but they have pretty poor long-term survival. Um, yeah, I think that's most of the things you need to know for this. Okay, fine. So we'll move on to chronic lung disease. Don't quite know why it says confusing categorization. But so as it says, we'll talk through obstructive and restrictive. Um, Firstly, let me just check if there's a slide on. Okay. Let's talk through the difference between obstructive and restrictive first. So obstructive lung disease is where, you have obstruction of the outflow tract, so the bronchi, um, rarely the trachea. But to differentiate these, they'll give you an FEV1 to FVC ratio. This ratio is reduced in obstructive, as you can see in the graph, reduced in obstructive lung diseases more than it is in restrictive. So in restrictive, typically you'll have zero point 0.7 or above, which is normal. And in obstructive, you would typically have zero point 0.7 or less. Usually they'd show you something that's less than zero point 0.6. But having said that, both FEV1 and FVC should be reduced in both of these. It's just the ratio that's changing. So FEV1 reduced more than to a greater extent than FVC is in obstructive, which makes sense because you can imagine someone with asthma or COPD, they can't breathe out as quickly into the tube that you would test these values with. Okay, obstructive diseases include asthma, COPD, cystic fibrosis, which is a cause of bronchiectasis. And then interstitial lung diseases are the restrictive ones. So these include all of those hypersensitivity, pneumonitis, and the pneumoconiosis, which are the occupational related lung diseases. Okay, we'll start with COPD. COPD is characterized by airflow limitation that's not reversible. So that's the key thing that they'll use to differentiate from asthma. You also won't have the sort of atopic history that they would give you in the STEM with asthma. And usually for asthma, they would present a younger person, like a child to young adult. The biggest risk factor is smoking. So check for that in the history. And this is like greater than, 10 pack years. That's a sort of level that they'll show you. The two sort of pathological elements are emphysema and chronic bronchitis. So emphysema you can see on this chest X-ray. It looks sort of darker than normal, and that's because you've got loss of or sort of expanded alveoli because the elastic recoil is sort of diminished. Um, and this also contributes to that hyperinflated lung, and so they can give you physical exam findings like the shortened cricosternal distance or barrel chest. In terms of the bronchitis, you'll have a productive cough, and it has to be greater than 3 months for at least 2 consecutive years. The pathophysiology there is hypersecretion of mucus. And so you can calculate the Reed index, which isn't very high yield for LabMed, but it's just the fact that they have the productive cough. Good. I think those are the main things for COPD. Oh, sorry. Before I move on to alpha-1 antitrypsin deficiency, they might tell you that the alveoli are damaged in a centrilobular pattern, which will contrast with the pan-acinar pattern seen in alpha-1 antitrypsin, which is here. I'll go back to bronchiectasis in a second. So alpha-1 antitrypsin deficiency is a genetic or like inherited condition. The inheritance pattern is autosomal codominant, basically autosomal dominant for exams. Alpha-1 antitrypsin is a protein that's secreted in the lung tissue and it inhibits neutrophil. Oh, sorry, apologies. inhibits neutrophil elastase, which is the protease. And so if you have a deficiency of this enzyme, we have increased activity of the neutrophil elastase, which is what's destroying the alveoli and, like in COPD, results in a loss in that elastic recall. Um, in terms of the presentation, they'll also present with liver failure because the misfolded protein can accumulate in the liver and cause cirrhosis. So if you see any signs of portal hypertension in someone who also has had a long-standing history of dyspnea and chronic cough, then you should be thinking about this pathology. And yeah, as I mentioned, the high yield key phrase pan-acinar emphysema rather than centrilobular emphysema for COPD. You can remember because two C's for COPD. Okay, going back to philosophy, to bronchiectasis. So bronchiectasis is just abnormal airway dilatation. There are a number of causes, including inherited things like cystic fibrosis or cartilaginous. The highest yield one to know is cystic fibrosis. The organism that, sorry, so if you have infection superimposed on your bronchiectasis, the most common organism will be Pseudomonas. This is the same for if you have cystic fibrosis, the most common cause of respiratory infections will be Pseudomonas. Um, But cystic fibrosis itself causes a multi-system disease due to a mutation in a chloride channel, the CFTR gene, and this mutation causes the abnormal protein to not be trafficked to the membrane. So it's not that the channel doesn't work, it's just that it's not in the appropriate place. Um, they'll probably tell you in the stem that the person is Caucasian. It's pretty frequent in this ethnic group, and it's an autosomal recessive inheritance. You can see bronchiectasis and specifically cystic fibrosis in this chest CT. So you can see these big dilated bronchi. They could also give you chest X-ray, but it's less likely. Okay, and then in terms of presentation, they'll present with those recurrent infections from respiratory infections from childhood, thick mucus, and because that chloride channel is also present in the GI tract, you'll have pancreatic first exocrine insufficiency, so they won't be able to absorb the fat-soluble vitamins because you won't have lipase from the pancreas. Um, and then that can proceed to endocrine insufficiency of the pancreas, so diabetes, hyperglycemia. Um, what else? Oh, so the fat-soluble vitamins themselves, they could describe those presentations. So vitamin D is maybe the one, D and K are the ones that they would test the most. Vitamin D deficiency, as you know, will present with an osteomalacia or rickets in a child. And vitamin K deficiency, they could mention that the person's had some abnormal bleeding, that sort of thing. And so if they have this combined with steatorrhea, so fatty stools that float, plus recurrent respiratory infections, they should be thinking cystic fibrosis. Male infertility in cystic fibrosis is due to um, bilateral absence of the vas deferens. It's not to do with any problems like ciliary problems. And then the diagnosis, sweat testing, you'll have increased chloride in the sweat because the channel works in the opposite way there than in the respiratory and gastrointestinal tract. You can obviously test the genetics um, and might have to test siblings, etc. as well. Okay. Okay, moving on to the restrictive lung diseases. So sarcoidosis is our first one. Here they'll typically say that someone has African descent or they're from Scandinavian regions. Um, in terms of the actual pathology, this is one of our granulomatous lung diseases, similar to TB in terms of the granuloma, but this is a non-caseating granuloma. You won't see that central cheese-like necrosis that they could describe in histology. And when you look at it, it'll just look sort of homogeneous and pinkish. You also get bilateral hilar lymphadenopathy. But sarcoidosis is a systemic disease. You'll have involvement in the skin. So you can see here erythema nodosum on the shins, reddish, purpley bruise-like patches. Um, Lupus pernio, so tip of the nose, having those like red, sort of like what you would get in lupus, but like, or sorry, SLE, but not sparing the nasolabial folds. Um, Also, parotid gland enlargement, arthralgias because it affects the joints. Basically, a systemic, something that sounds like an autoimmune condition, but with bilateral hilar lymphadenopathy, and they'll tell you about the granulomas. In terms of the diagnostics, you can check for serum ACE, so angiotensin converting enzyme. Um, but they could also tell you that they have hypercalcemia. And this isn't because of like excess vitamin D, it's because the macrophages that form the granulomas secrete the 1 alpha hydroxylase that activates vitamin D. Does that make sense? So we have a state of hypervitaminosis D without actually an excess in the vitamin D itself. Oops. Okay, moving on to pulmonary fibrosis. Here, the high yield phrases they'll use in the LabMed stems are the honeycombing of the lungs, and you can see on the chest CT it sort of looks like honeycomb. Um, this chest X-ray is really characteristic. It looks very white, and they might call it a reticular nodular pattern. You can see these lines and dots that you wouldn't see in a normal chest X-ray. Um, this is a restrictive lung disease, so you can't, there's no problem in sort of like expiring. It's more like the recoil and the filling is bad. In terms of clinical features, they'll describe the late inspiratory crackles at the bases, clubbing, and dry cough, as opposed to COPD, which is also going to have a chronic presentation, but that's a productive cough. Mm. Yeah, and so you do chest X-ray and then CT um, for investigations. Okay. Okay, hypersensitivity pneumonitis. This isn't as high yield for LabMed, but you should know the associations. So which exposures cause which disease. So moldy hay obviously will cause farmer's lungs. These are all sorry, before I go on to those, they're all to do with antigen, repeated antigen exposure. Um, they can present with in a chronic phase, so with dyspnea and cough, non-productive cough. But they can also have an acute phase, so you can have raised temperature. Um, what else? Sort of an acute onset cough. But you should check the key things here when they tell you about these exposures, it should direct you down that path rather than pneumonia or infection. Okay, so as I mentioned, moldy hay for farmer's lung, bird protein, so someone who has like pets at home or works in zoo. Um, then barley for a malt worker's lung, and house dust can cause a general sort of antigen exposure. Um, House dust, don't get confused about this as a trigger for asthma. This would be an obstructive lung disease, and again, it would be sort of the recurring triggers of asthma attacks rather than a chronic cough and breathlessness. Okay, and the pneumoconioses, again, the key thing is to look at environmental exposures in the history. So if they're telling you shipyard or working with machinery, then asbestosis, um, coal miners, the coal dust exposure, beryllium for people working with sort of planes and things like that. And then in terms of histology findings, I'm going to add these to the slides, but sorry, let me just check if they're on the next slide. Okay. I'll add these to the slides, but for asbestos, the key thing is the ferruginous bodies, and I'll add a photo as well of the histology. Um, these aren't the asbestos being taken up by macrophages, and you'll be able to see them on the slide. And for beryllium, this is also granulomatous disease, so like sarcoidosis, non-caseating granuloma, but you won't have the systemic findings in sarcoidosis, and you won't have or they won't mention that they're African or things like that. In terms of presentation, it's basically the same as IPF, so inspiratory crackles, fine crackles at the base of the lung, but differentiate by history. Okay, almost done with lungs, kind of. Pulmonary vascular disease. So DVT and PE are simpler than the others. So DVT is precipitated by, any component of Virchow's triad, which is the stasis, endothelial injury, and hypercoagulability. So any risk factor associated with those. So for endothelial injury, things like trauma, um, smoking. For stasis, immobility, just old age, long flight, or recent surgery and the things in a cast. And then hypercoagulability, they could tell you cancer, pregnancy, or one of the inherited coagulation defects that you talked about in hematology. In terms of the presentation, it's a acutely painful red leg, so that will differentiate from, any embolic arterial embolism in the leg, which will be a painful but cold and white leg. So here, a red, painful leg. You can also get superficial veins being distended and edema, and usually, obviously, unilateral. And then when that thrombus sort of detaches from the vessel wall and goes to the lungs, it becomes pulmonary embolism. Here, in terms of presentation, if they ask you about ECG findings, then sinus tachycardia is the most common, but they, sometimes this is more relevant for AKT, but they can tell you about the S1, Q3, T3. They can also present with hemoptysis, and it's a cause of pleuritic chest pain, so pain on breathing in, and they won't be moving around very much. These two, so amniotic fluid embolism and fat emboli, are on your syllabus, but they're very small print. And sometimes they'll try to trick you by saying that the person is pregnant, and you might think that it's an amniotic fluid embolism, but it's much more likely to be DVT because of the pregnant hypercoagulable state. Good. Okay. And they might ask you about DVT prophylaxis or treatment of PE, as you mentioned in your heme lectures. So have a look at the thrombolytics and anticoagulants and their mechanisms of actions. So the key ones here are like heparin. Okay. And then the rest of the pulmonary vascular diseases they want you to know are pulmonary edema. So typically you can split these into two causes, either increased hydrostatic pressure within the vessels, which sort of pushes the fluid out. And here the most high yield cause for LabMed is left heart failure. So pressure building up the ventricle can't pump out the blood, so it backs up into the atrium, then the pulmonary veins, venules, and then the capillaries, and there it's increasing the pressure. And then in terms of decreased oncotic pressure, so outside the vessel, sort of pulling fluid out. Here, the highest yield causes are things like nephrotic syndrome, which will leak albumin out via the glomeruli, or liver disease, sort of like late stage cirrhosis or liver failure. Okay. And then acute respiratory distress syndrome. For the presentation, it'll be someone who's been in hospital for a while, so sepsis. Sometimes it's a complication of acute pancreatitis, but I think sepsis and burns, those are the most high yield for LabMed. Here on the chest X-ray, you can see that it's sort of a diffuse bilateral opacities. You can't really see as in like, how would you differentiate this from idiopathic pulmonary fibrosis? Here it's much more like patchy rather than the lines, the reticulonodular lines and dots that you can see with fibrosis. And in terms of histology, they'll talk to you about hyaline membranes, that's very high yield. but the actual pathophysiology is endothelial damage, damage to the capillaries, which causes a release of cytokines, and you had a big neutrophilic infiltrate. And so they can describe this as an inflammatory exudate in the lungs. Great. Okay. Um, Moving on to respiratory infection, they want you to know about the sort of definitions of upper respiratory tract versus lower respiratory tract infections. So upper is larynx and above, so things like um, tonsillitis, laryngitis. Lower UTI is tracheitis, um, bronchitis, and then also includes things like the pneumonias, abscesses, empyema, which is like pus in the pleural space, and mycobacterial infections. And we'll have a separate section on that. In terms of lobar versus atypical pneumonia, lobar pneumonia, as you can see quite clearly on chest X-ray, it's just one lobe affected, dense consolidation. Atypical pneumonia is more patchy, bilateral usually, and those are caused by those atypical bugs. The three you'll need to know are like the chlamydia species, um, Legionella, Mycoplasma, sorry. For lobar pneumonia, the pretty much always, almost always in the community caused by strep pneumo, but can also be caused by Haemophilus. We'll talk about the causes of hospital-acquired pneumonia on the next slide. In terms of the upper respiratory tract infections, I think the most important ones are pharyngitis, and the cause of that, mostly the group A streps, so strep pyogenes. And you'll need to know, so you should be able to link these with the sort of cardiology and renal sections. They could ask you about, a child has sore throat, tonsillar exudates, sorry, pharyngeal exudates, and then 2 weeks later presents with hematuria, and you should be able to recognize that this is post-streptococcal glomerulonephritis or rheumatic fever, so sore throat and then having onset of a new murmur, intense fever, and those Jones symptoms, so arthralgias, nodules, and rash. Empiric treatment for strep pyogenes pharyngitis is penicillin. If they're penicillin allergic, then you can give clarithromycin or doxycycline. That's not so high yield. The penicillin is highest yield for LabMed. And then finally, knowing which viruses can cause upper respiratory tract infections. The most common ones are influenza, coronaviruses, RSV, and EBV slash cytomegalovirus. So RSV is important in terms of being a cause of bronchiolitis. So small child, like months old, child presenting with sort of cough, distress, tachycardia. This is RSV, and the treatment is just supportive care. EBV and CMV will be more relevant for causes of infectious mononucleosis, so teenager slash young adult presenting with kind of fever, swollen lymph nodes. Those are sort of the main things. We'll discuss EBV and CMV in the microbiology lecture as well on Thursday. We'll talk through histology. Okay, and then for lower respiratory tract infections, we've already talked about community acquired pneumonia. So the most important causes are strep pneumonia, which is a gram-positive diplococcus. I could say that on the question stem, or Haemophilus. For hospital-acquired pneumonia, you can use this mnemonic, keep sick. Here, the important thing is Pseudomonas. They can ask you about which drugs will cover Pseudomonas. Again, it'll be covered in micro. Finally, CURB 65. It predicts mortality, but this is kind of used as a proxy of severity. And so you should learn all of these: very high yield, confusion, urea, respirate, blood pressure, and the age. And you should learn the exact values as well. They can give you just a description of a patient and ask you what's the score. So an easy mark. I don't think okay, sorry. Let me just quickly go back. For the other lower respiratory tract infections, They could show you a chest X-ray. We'll have a question later. Um, with an air fluid level. So you'll have sort of a black space and then a clear horizontal line. This is a lung abscess. For risk factors for that, they could describe in the patient's past medical history a cause of aspiration, so things like neuromuscular dysfunction, things like motor neuron disease or myasthenia gravis, which makes you more likely to swallow things into the lungs. Um, yeah, and they can also say things like they're an alcoholic, that also increases the risk of aspiration. We'll go through the other risk factors when we do the questions. Okay. Here are some buzzwords that they like to use in the questions for respiratory infections. Um, Legionella pneumonia. So I said the atypical pneumonias, they'll describe these as bilateral patchy pneumonias. Um, Legionella, they'll talk about the liver function test being deranged. In terms of risk factors, they'll say someone just came back from a conference, so you can infer that they had bad aircon or cruise ships. And hyponatremia is characteristic of Legionella pneumonia. And the diagnostics, you'd have to do a urinary antigen. In terms of the other atypicals, from mycoplasma, that's typical in a sort of young person. They'll describe it as a walking pneumonia. So they're going about their day. They don't seem so sick, but the chest X-ray looks quite bad. Okay. If they mention alcohol or diabetics in the question, then the most common organism kind of would be Klebsiella. They could also mention lung abscesses. Klebsiella likes to form that sort of lesion. Um, Exacerbation of COPD is Haemophilus, and the same with sarcoidosis. So you can think this is exacerbation of an existing lung disease, Haemophilus. The only exception to that is cystic fibrosis we mentioned earlier on. That was Pseudomonas. These like animal-related zoonotic organisms aren't that high yield for LabMed, but I've included a list here just for you to read. If they mention parrots in the question, this chlamydia species can cause an atypical pneumonia. Okay. Finally, last bit for lung, TB. So this is a mycobacterial infection, Mycobacterium tuberculosis. The presentation can be very similar to cancer, so cough, night sweats, fever, hemoptysis, weight loss. To differentiate, look for things like if they were born outside of the UK, if they've had recent foreign travel, and for cancers, they will describe the paraneoplastic syndromes or they'll show you histology, whereas here they'd show you the granuloma histology. Apologies, I don't have a picture. I'll add that to the slides as well. I think I mentioned before, this is a caseating granuloma. Um, Compare this with the non-caseating granuloma of sarcoid and borreliosis. You'll see a clear like central necrosis. In terms of like how it occurs, so primary TB will infect the middle lobe. It's not super important, but the fact that the lesion in the lung plus the hilar lymph nodes together, that's called a Ghon complex. If this calcifies, it becomes a Ranke complex. The terms aren't that important, but just the fact that the hilar nodes are involved. Then secondary TB is more likely to be the apex of the lung. This is the where you get those presentation of hemoptysis, weight loss, night sweats, and you'll find the caseating granuloma. Typically, in a immunocompetent person, the primary TB would just resolve and form a granuloma, wall off the bacteria, and it will just stay as latent TB. And in terms of the treatment of active TB, I've given you this mnemonic, too ripe for rye, I guess. So rifampicin, isoniazid, pyrazinamide, and ethambutol for 2 months, and then just rifampicin and isoniazid for 4 months. Don't confuse the P in ripe, pyrazinamide, for pyridoxine. Pyridoxine is supplemented throughout the whole treatment, and it's vitamin B6, they could say either, and it's because isoniazid causes vitamin B6 deficiency. If you don't supplement this, they can present with a peripheral neuropathy. Okay, and then we'll talk about the tests for TB. Culture has the highest sensitivity, so if they ask that in a question, I think they can do that. That's the gold standard, and they would use an acid-fast stain, Nielsen stain. Um, but culture takes weeks to come back. So instead, you can just do chest X-ray, look for symptoms. This will show you that there's active TB. Um, then in terms of diagnosing latent TB, they would have a positive interferon gamma test, IgRA test. Um, but you can also do a tuberculin skin test, which is injecting the tuberculin protein or a purified protein derivative, and then read 72 hours. So they 72 hours later, they can link this in with immunology as well, with the hypersensitivity reactions. So you should know that this is because it's 72 hours later, it must be a delayed hypersensitivity reaction, so type 4, which means that the infiltrate around that, so the lump, or like, sorry, the swelling, that sort of thing, redness, is caused by T cells infiltrating and then recruiting macrophages. Um, Good. So there are some exceptions to those two tests, like when you use them. So IgRA preferred in people who receive the BCG vaccine because you would get a false positive on the tuberculin skin test. And then the tuberculin skin test preferred for young children. Okay, so we finished RESP. I'm going to start the Socrative and we'll try some multiple choice questions and review. I just need to get another device. I'm going to be back for, I'll be back in 1 second. Okay, so I've started the Socrative. The code for the room is OSME. I'll just wait for people to join. Yeah, I can see a couple of you on the question. Um, you should be able to get the answer once you submit. Okay, so we'll just go through the answer for the first one. So 59-year-old smoker presenting with chronic cough, mass adjacent to the proximal left main bronchus, and the tumor is highly cellular, composed of cells with minimal cytoplasm and hyperchromatic nuclei, displaying molding and smearing. What's the most likely cell of origin? So I can see that most people have put the correct answer, neuroendocrine cell. Um, but a couple have chosen squamous cell, which is actually the best second option. So here, this is a smoker, so risk factor for small cell lung cancer and squamous cell, and it's a central tumor. They've said it's adjacent to the left main bronchus, so both of those are still, um, it still fits with both of those. Here, you need to know the histology. These small blue cells, and they're describing them as molding and smearing, hyperchromatic nuclei, and the key thing here is the minimal cytoplasm. It's essentially saying that it's a small cell. And then if you know that it's small cell lung cancer, then you should know that the cell of origin is a neuroendocrine cell, or they could say Kolchitsky cell. Okay, move on to the next one. These are quite long question stems. You probably wouldn't have this much stuff in the actual LabMed exam. They like to focus on the positive findings. So don't worry too much about that. Just I'll just wait for a couple more answers, then we'll review. Okay, so this is actually a ridiculously long stem for just a couple important findings. So 55-year-old female, shortness of breath, productive cough, green sputum, pleuritic chest pain. So they're saying it's painful to take a deep breath, raised temperature, and here lung sounds decreased over the left lower lung and denser pacification. So this could be Well, okay, it's most likely to be a pneumonia, as most of you had said, because of the green sputum. So, the color of the sputum is because of the MPO in neutrophils, the enzyme. And so that points you towards infection, along with the temperature and the consolidation. A tumor typically wouldn't present with a productive cough. If it's productive at all, it would be hemoptysis, so blood. Um, You could get fever with tumor, but it's not as likely. You're more likely to get night sweats. Okay, next question. It's slightly shorter. Let's give you guys another minute to respond, and then we'll review. Okay, I'm getting mixed answers with this one. So some of you've got the right answer, lung abscess, but I've got some TB and middle lobe pneumonia as well. So we'll go through the question. So presenting with an old woman, presenting with productive cough, foul smelling sputum, worsening fatigue. Her respiratory symptoms started 2 weeks ago, and she's got recent onset of night sweats. And in the past medical history, Parkinson's, arthritis, asthma. She's fatigued and has an expressionless appearance, resting tremor, raised temperature. So these are all plausible, actually. The tuberculosis with night sweats and raised temperature, and middle lobe pneumonia. The thing that's pointing you towards lung abscess is then only the chest X-ray, which shows, if you can see on the picture, there's a really sharply demarcated horizontal line separating a denser bit at the bottom and more black area at the top. That's the air fluid level we were talking about, and that's pathognomonic for a lung abscess, basically. So the fluid collecting at the bottom of the abscess. She's got a risk factor, so her Parkinson's disease. I mentioned before that risk factors include aspiration, so anything that affects the neuromuscular junction slash coordination, swallowing, anything that causes dysphagia, things like that, are risk factors for aspiration. Other risk factors for abscess I've included in the explanation. So oropharyngeal bacterial overgrowth. So if they describe someone with really poor dentition, that's also a risk factor for endocarditis if they've got damaged valves already. Immunocompromise, you can see in this older woman who's got osteoarthritis, probably taking some steroids for asthma. Um, She's probably immunocompromised as well. Impaired mucociliary clearance, so cystic fibrosis is a risk factor for abscess, and bronchial obstruction. So if you have a primary lung tumor, anything that's obstructing the bronchi, that can also increase your risk of abscess. So this is a tricky one, and maybe more likely to come up in your AKT as well, because you should be interpreting chest X-rays then. So a mean one for LabMed. Next one is up now. Okay, perfect. Everyone's got the right answer. Curb 65. Um, he's got pneumonia, obviously, left-sided consolidation, and raised respiratory rate. Confusion. They could give you the same sort of vignette, so the same question stem, and ask you to calculate curb 65 as well, if they had the urea and things. Oh, okay, that's it. Sorry. We'll pause that and go on to immunology. Come back to the rest of the questions. Okay. Try to get through all of it. Sorry, I've left it. I've not done the timings very well, but we'll just go through the high yield content. So starting off with the hypersensitivity reactions. You should be able to think sort of off the top of your head of a couple of examples of each type. Type 1 is sort of immediate, so things like anaphylaxis, hay fever. This is IgE mediated. So IgE binds its receptor on mast cells, causing degranulation and release of histamine. And then the histamine itself causes vasodilation. Other granule contents can cause sort of pruritus or itching, and yeah, the vasodilation and swelling are histamine mediated. In terms of diagnostics, so IgE, but also tryptase will be elevated from mast cells. Type 2 is just antibodies. You can think of these as maybe becoming more complex. So type 2 is just antibodies versus type 3 is immune complex, so antibody with something bound depositing somewhere. So examples for type 2 include things like Graves, ITP, so immune thrombocytopenic purpura, Graves' disease, so linking with your endocrine, you should be able to, if they give you a hyperthyroidism question stem and ask you what type of hypersensitivity mediates that, you should know it's two. Um, all of the others, so pemphigus vulgaris, you'll have a skin session and they'll discuss these. So IgG against desmosomes and hemidesmosomes. Good pasture, so anti-GBM antibodies and myasthenia gravis. Anything where it's just a single antibody binding its receptor causing pathology. Versus type 3, which is immune complex. I think the main one you need to know for LabMed is lupus. Um, yeah, usually biopsy, you'll see the complexes in for lupus in the kidneys. It can also cause, like joint pain and the skin lesions. Those are also immune complexes depositing in those spaces. Type 4 is significant in that tuberculin skin test. They can also call this PPD test, MAN2 test. As I mentioned before, it's T cell mediated. Um, so the antigens, antigens sort of being recognized by T cell receptors. Again, this one also requires prior sensitization as well as type 1. So for type 4, sorry, so the MAN2 test and allergic contact dermatitis is the key one that they can test. If they tell you that someone's been wearing a certain belt for a couple weeks and suddenly they've got a pruritic rash, then it's probably allergic contact dermatitis. It'll be localized to where the contact is happening. So ring, belt buckle, things like latex gloves. Okay. And for here, the diagnostics are patch testing. So compare patch testing with skin prick testing. This will only take 5 minutes versus patch test, like the PPD test, you'll have to wait 72 hours or so. Okay. For type 1 hypersensitivity, I mentioned anaphylaxis, and you should know the presentation. So hypotension, you can go to anaphylactic shock, which will present as dizziness, fainting, thready pulse. Respiratory symptoms, so wheezing, dyspnea, and then the characteristic urticarial rash, which is pruritic and sort of raised, well demarcated, but edematous. Um, and then GI symptoms like vomiting, pretty non-specific, but it's quite obvious in the stem. They'll tell you that someone's, just eaten seafood or been out to a meal even. Um, Allergic triggers, so like I was saying, the food or things like bee venom require prior exposure, but you can have some things that directly um, trigger the mast cell to degranulate without needing the IgE. So things like radio opaque contrast or certain medicines. And for here, you wouldn't need the sensitization because the sensitization is what produces the IgE that triggers degranulation, if that makes sense. In terms of management, this is one that you do need to know for LabMed. Typically, management is reserved for your AKT paper, but here you should know that it's managed with adrenaline and it's intramuscular. The dose isn't as important for LabMed. Okay. Moving on to the vasculitides, I think people have some trouble with this because they're so similar, like the large versus medium vessel and small vessel. The diagnostics you sort of just have to memorize, and the presentations are all similar but slightly different. Um, in terms of the definition, vasculitis just means inflammation in the walls of blood vessels, um, and that can result in thrombosis and tissue ischemia. Some vasculitides are pretty localized, so affecting a single organ, things like the kidney, but lots of them are systemic symptoms. Um, You can have primary vasculitis associated with, so especially the small vessel diseases associated with anchor antibodies. So these are anti-neutrophil antibodies. There are two different types. We'll talk about them later. And secondary vasculitis can be associated with infection, or malignancy. Infection is the one that they can ask about. The other secondary causes aren't so important. Um, yeah, we'll talk about the effects and things for each specific one. Okay, so as I mentioned, we can categorize the vasculitities into large vessel, medium vessel, and small vessel. The large vessel ones are easier to remember because their symptoms are so distinct. So you can have giant cell arteritis, which is also called temporal arteritis. So this is one of those specific localized vasculitis where you have granulomatous inflammation in the vessel wall in the temporal artery. Um, you can have these skip lesions, so you have to do biopsy, but it might be normal, you can miss lesions. Um, in terms of the presentation, this will pretty much always in LabMed be a really old, not really old, an older woman, sort of over 55. And they'll present with headache or jaw pain. Otherwise, if they're presenting later, they can just present with sudden onset blindness, painless blindness. It's also associated with polymyalgia rheumatica, which can present with sort of stiffness in the shoulders and hips. Not really muscle weakness, but pain and stiffness. In terms of investigations, actually, before investigations, you should, if you suspect this clinically, we give IV urgent prednisolone, and this is to prevent blindness. They could ask you what they give and why in LabMed. But in terms of investigations, you would have a raised inflammatory marker, so ESR. And if you do perform ultrasound guided biopsy to confirm the diagnosis, you would see those granulomatous inflamed portions. Okay, the second large vessel, maybe the only other, yeah, the second and last large vessel vasculitis that you need to know is Takayasu disease. Again, it's a pretty, like, they'll give you a young-ish woman, 20 to 40, probably Asian, like East Asian, because that's the like typical demographic. Um, but they won't give you risk factors for arterial disease, so they won't be smokers, they won't have diabetes. It's also known as pulseless disease, which can help you remember you'll have mismatched pulses in the arms. Again, this is granulomatous inflammation, and it's the aortic arch and the origins of the great arteries. Um, so because it's the vessels that branch off the aortic arch, that's what leads to the loss of lower limb pulses or the mismatched upper limb pulses. In terms of investigations, angiography, and again, biopsy well, you don't typically do biopsy because it's the aortic arch, but it would show granulomatous inflammation. So if you just remember large vessel vasculitis, granulomatous inflammation. Perfect. Okay. Then onto the medium vessel vasculitides. The first one is polyarteritis nodosa. This is necrotizing inflammation of the artery supplying the viscera. So if someone presents with abdominal pain, but also sort of some neurological features, so things like peripheral neuropathies or mononeuritis multiplex, so sort of like single nerve palsies, or peripheral neuropathy, as I mentioned, like like you might see in things like diabetes or vitamin B6 deficiency. They'll have pretty like non-specific symptoms, so fever, myalgia, arthralgias. A lot of the vasculitis syndromes present like this. Um, but the key things to note in the history, they might say that they're hepatitis B positive, so chronic Hep B infections. Hep B is associated with polyarteritis nodosa. You won't have ANCA. If they do ANCA antibodies, they won't be positive. The ANCA ones are associated with the small vessel vasculitides. And then on biopsy, as I mentioned, necrotizing inflammation. Treatment, as with the last one I didn't mention, are steroids, so prednisolone, and or cyclophosphamide. This isn't a very highly tested vasculitis. In terms of what's high yield, I think the large vessel, so they like to test giant cell arteritis a lot, and the small vessel ones. Okay, another medium vessel vasculitis. This is really important, like clinically actually, in children who are presenting with fever for, over 5 days. And you get these really classic skin lesions, sort of sandpaper-like rash all over the body, and desquamation, so a peeling rash. You'll also get cervical lymphadenopathy and conjunctivitis. So these three symptoms are the most important to learn. So the rash, conjunctivitis, cervical lymphadenopathy, sorry, and the high fever that's unexplained by infection or anything. The important association here, so the disease itself is so scary and it has to be picked up because it can cause coronary artery disease, coronary artery aneurysm. And so if in a child they're having a myocardial infarct, this is basically the only cause. Any other, even inherited, um, like hyperlipidemia, wouldn't present so early on in life. Um, To look for those cardiac aneurysms, coronary artery aneurysms, we do echo or angiography. And again, the treatment, like with the other um, vasculitis with a serious complication, so giant cell arteritis and blindness, we treat with high dose steroids. Okay. Before we go on to the small vessel vasculitides, I'll discuss the two types of anchor antibodies. So as I mentioned, they're anti-neutrophil cytoplasmic antibodies. And there are two types, P anchor or C anchor. But in question stems, they could use the other words for them. So for P anchor, this is the same as anti-MPO, myeloperoxidase. And for C anchor, anti-PR3. Sorry, I appreciate this is a lot of like facts that just have to be memorized. But I'll get the slides over to you after this. And we'll go through some questions as well. Okay, there are three small vessel vasculitides that are important to know, and then one other that's sort of linked to your renal module. So the first one, GPA, it used to be called Wegener's, but sorry, now it's granulomatosis with polyangiitis. This is the only small vessel vasculitis that's C anchor positive. The other two are P anchor. This affects both the kidneys and the upper airways. So classically, they'll present with sinusitis and sorry, otitis, so like head and neck. Nasal findings, so physical exam findings include loss of septum and saddle-shaped deformity. And then in the lungs themselves, you'll get hemoptysis. As I mentioned, in the kidneys, you get this necrotizing glomerulonephritis. So just to summarize the presentation, hematuria, so glomerulonephritis, plus hemoptysis, so coughing up blood, so lung lesions, plus like weird nasal deformities, like loss of septum, and they'll be positive for C anchor, which is the same as anti-PR3. Um, for all of these small vessel ones, the treatment is steroids to suppress the inflammation. Okay. The second one, as I said, the next two are P anchor positive. This one is eosinophilic granulomatosis, um, and can be called Churg-Strauss as well. Like the other, this is necrotizing vasculitis, but you also have eosinophilia. So if you do bloods, you'll find that as well as P anchor. Here again, it's hard to differentiate because this one also affects the sinuses and the upper airways. It's less likely to have kidney involvement though. So if you have kidney plus lungs, then GPA, just sort of hemoptysis and sinusitis is more likely to be Churg-Strauss. What else? Again, treatment with steroids. Okay, and then finally, microscopic polyangiitis. Again, P anchor. Here, this is again glomerulonephritis and pulmonary hemorrhage. As I mentioned, all of the presentations are quite similar. To differentiate the two P anchor positive ones, look for renal involvement. And then to differentiate the other one, they should tell you in the question that it's C anchor positive. For all of these three vasculitides that I've just talked about, they could test you on, from the renal side of things as well. You've talked about nephritic syndromes. They all present with RPGN, so rapidly progressive glomerulonephritis. And if you can recall, that has the sort of crescentic deposits of fibrin and cells. Okay. The last one, the only small vessel vasculitis that's ANCA negative is Henoch-Schönlein purpura. This is an important PEDS differential. In terms of the pathophysiology, it's IgA immune complexes deposited in the glomeruli. And in children, it will present with hematuria because of this glomerulonephritis, plus these palpable purpura on the buttocks and thighs. Yeah, I think the buttocks and thighs thing is more commonly said than pressure sites that it says on this slide, so I'll change that. They can also present with sort of abdo pain, um, because that can affect the arteries in the sort of GI tract as well. But the key things are this rash and the renal findings. And the IgA is very important to remember. Okay. Okay, moving on to the systemic autoimmune diseases. The other subject-specific autoimmune diseases should have been covered, so the endo ones and renal and things. So I'm just talking about the systemic ones. So first one, Sjogren's. This is really, as in it'll be obvious if someone's presenting with this in the question because they have the dry eyes, dry mouth. They'll feel like they have dust in their eyes all the time. Um, Good. For all of these, the key things are to learn the antibodies. So what do you test for? Here it's anti-Ro and anti-LAR. They can also call these anti-SSA or SSB. Um, the Schirmer's test for tear production isn't as highly tested. The antibodies is more significant. Um, on biopsy, so you can do biopsy of the like lip and you'll see a T cell infiltrate. Again, that's not as high yield as the antibodies they use. For all of these autoimmune diseases, they all sort of associate with each other. So if someone presents with, or someone has a diagnosis, existing diagnosis of SLE, and then they present with dry eyes, dry mouth, it's more likely that they have another autoimmune condition. The actual pathology is the exocrine glands are the ones that are involved. And because the lacrimal and salivary glands are destroyed, they won't be able to produce tears or saliva. Okay, scleroderma. Um, there's two types, and you need to know the two different antibodies that are associated with them. For CREST syndrome, you get anti-centromere antibodies, versus diffuse systemic sclerosis has anti-SCL70. That's actually the main thing you can learn. Sorry, the CREST symptoms. So you'll have sclerodactyly, so if they have any strange skin findings on the hands, and esophageal, so if they present with dysphagia, and Raynaud's. So Raynaud's, esophageal dysmotility, and sclerodactyly. Then think limited. If they have sort of a non-specific diffuse illness, then diffuse systemic sclerosis. Oh, this is what I was talking about, the skin findings on the hand, so thickening and tightening. All of these sclerosis symptoms are to do with fibrosis, which sort of explains all of them. So if you see any symptoms that hint towards that in the question stem, then it's going to be CREST. Okay. For all of those autoimmune diseases, there's a list on your syllabus. As I mentioned, the most high yield thing for LabMed is to learn the associated antibodies. Okay. Moving on to the immunodeficiency syndromes. Again, this is a lot of things just to memorize, but if you understand sort of the principle, so if you understand what enzyme slash which receptor is affected, then you should be able to understand which infections they should present with. Sorry. So we'll start with X-linked A-gamma globulinemia. Here there's developmental arrest at the pre-B cell stage because of an X-linked mutation in BTK or Bruton tyrosine kinase. Um, because they arrest their development at the B cell stage, you'll have sort of normal bone marrow, but the B cells won't enter the circulation and they won't be present in the tonsils or the lymph nodes. So these patients won't have tonsils or lymph nodes. And obviously they won't have B cells on like a full blood count as well. And as it says in the name, A gamma globulinemia, there's no immunoglobulins. And so they have recurrent infections, especially pneumonias, otitis media, sinusitis. And they say males because obviously it's X-linked recessive. This will help you differentiate this disease with no immunoglobulins with common variable immunodeficiency, which will be in older women. I'll come on to that in the next slide. Okay. Hereditary angioedema. Um, the key thing to remember is here the presentation. So they'll present with sort of similar symptoms to what you would get in anaphylaxis, so swelling, edema, especially around the mouth and airways. The deficiency is in C1 inhibitor, which eventually the cascade isn't so important, but because of a lack of this, we have a buildup of bradykinin, which is what causes the vessel wall permeability and edema. Um, Good. Next is severe combined immunodeficiency. They haven't included the mechanisms here, but there are different causes. You can have defects in the IL-2 receptor, defects in the RAG complex, which is what causes the VDJ recombination in the B and T cell receptors. The mechanism isn't so important. The presentation will be someone who's very young, failure to thrive, they'll have failure to thrive plus chronic diarrhea and recurrent upper respiratory tract infections. And both B and T cells will be absent. So that's the thing that will differentiate from some of the others with failure to thrive. Okay. Common variable immunodeficiency. This is what I said before. So if you have a blood count with low immunoglobulins, your differentials are Bruton's versus CVID. But Bruton's will be very obvious. It'll be a young boy, and CVID will be sort of older, typically woman, but it can be anything. And they present similarly, so recurrent sinopulmonary infection. Okay. Next, leukocyte adhesion deficiency. I'll add some more detail to the slides after this, but here the defect is in neutrophil chemotaxis. So the neutrophil, sorry, literally adhering to the vessel wall because there's a defect in integrin. So they can call this LFA1 or CD18. The key feature in the presentation is if they say there was delayed umbilical cord detachment, the stump leg wouldn't fall off. And in terms of their recurrent infections, you'll see that there's neutrophilia, so high neutrophils in the blood, but there's no pus at the site because they can't like stay on the vessel. Does that make sense? They can't infiltrate. Good. Because you need adhesion before extravasation can happen. No. Okay. One other that's not on the slides that I'm just going to briefly talk through is chronic granulomatous disease. This is a defect in the sort of oxidative burst. So this is how neutrophils kill like bacteria. You'll have recurrent infections with specific organisms that are catalase positive. So things like Staph aureus, Aspergillus, Nocardia. Yeah, I'm just gonna start the Socrative again. There's a couple of questions on hypersensitivity and immunodeficiency. Um, just 4 questions. Feel free to go back on, and again, I'll talk through the answers. And I appreciate it's 7:30, so I'm going to leave the feedback form as well. If any of you need to go, then you can collect the slides and head off. Thank you. Just wait maybe one more minute for people to answer. Everyone's getting the answer right. So this is a 24-year-old woman, severe itching and dizziness, so hypotension, pruritus, a few minutes after an intramuscular injection of an antibiotic, lip swelling, and she's been given the same antibiotic before with no obvious problems. So here they've clearly described the sensitization phase. So this is not the direct mast cell activation that you can get with some antibiotics, but it's the normal IgE mediated mast cell degranulation. And this is a type 1 hypersensitivity response, which is why it's immediate. Perfect. Okay. On to the next one. So I'm looking at the question. It's kind of mean. It's to do with bone, but um, maybe you can guess and we'll just talk through the reasoning. This is one of the more integrative ones, so combining this um, immunology with the bone and joint section. Okay, so a couple of you've got the right answer. Apologies, this is probably in the wrong talk, but so she's been treated for giant cell arteritis. As you can see, this is the demographic that they would have in LabMed questions. So an older woman. If they didn't tell you what she was being treated for, they would say that she presented with unilateral jaw pain or a bad headache. Um, yeah. And as I mentioned, the treatment is important and high yield to know for LabMed. IV steroids if there's any clinical suspicion to prevent blindness. Um, Steroids and corticosteroids can cause osteoporosis, in the same way that you have osteoporosis in Cushing syndrome. And further, it tells you on this examination finding that there's sort of point tenderness over a vertebra and a wedge-shaped vertebra. Um, when it says wedge-shaped, it basically means it's a compression fracture, and osteoporosis is a risk factor for a compression fracture. So that's why the answer is osteoporosis here. But obviously, we'll cover this during our bone session. The high yield point is just to know giant cell arteritis treated with IV prednisolone. Okay, last couple of questions. Okay, so 6-year-old boy, so PEDS presentation with rash, abdo pain, nausea, vomiting, um, denies any change in urination or hematuria. There's no edema. But they're saying if performed, then what would be seen on renal biopsy. So here, this is um, HSP, Henoch-Schönlein purpura. And as I mentioned, this is an IgA complex mediated disease. Um, if this, yeah, so the renal findings don't always, sorry, the patients don't always present with hematuria, but the pathogenesis is this IgA deposition in the vasculature. Um, some of the wrong answers have been granulomatous inflammation in glomerular vessels. So the granulomatous vasculitides are typically the large vessel vasculitis. So um, GCA, so giant cell arteritis, or Takayasu, or the Wegener, so granulomatosis or polyangiitis, and Churg-Strauss. Why is it not those? So you don't typically see a rash in GP or this sort of rash in GPA or Churg-Strauss. There they would mention the sort of hemoptysis, the lung findings a bit more, and the sinopulmonary, so the otitis media, that sort of thing. Um, the rash on lower legs and buttocks in kids is pretty much always HSP. Okay, and then final question. These questions are all like maybe very slightly harder than what you would get in LabMed. Some of them are integrated in this way, but you'd get a higher proportion of questions that would just ask you the diagnosis. I thought since it's just a revision lecture. Um, okay, I'm just going to go through this question. This is my fault entirely. This pathology was not actually on the slides, and it is in your syllabus, so I'm going to talk through it now. Okay, so this is a 7-year-old boy presenting with 5-day history of cough and nasal discharge, and these are recurrent according to his mother. Past medical history includes major open heart surgery and repair of cleft palate. Lightly tapping the patient's cheek elicits a spastic-like contraction of the facial muscles. Okay, so let's go through the findings in the question first. So tapping the patient's cheek and spastic-like contraction. This is something that they might have discussed in your biochem module. Chvostek sign is a sign of hypocalcemia. The other sign of hypocalcemia that you need to know is Trousseau sign. So twitching in the hand when you inflate the blood pressure cuff. Okay, so we have someone with hypocalcemia, recurrent infections, and congenital cardiac defects. And these are all consistent with DiGeorge syndrome, which is a 22q11 deletion, microdeletion syndrome. And here you have failure of the sort of third and fourth pharyngeal arches, so you don't get the structures that are derived from those. So the parathyroids and the thymus, which is a site of T cells. So you get an isolated T cell deficiency as well as those hypocalcemia signs because you don't have parathyroid hormone. And the pharyngeal arch developmental defect also can cause cardiac, like congenital cardiac defects, which is why there's open heart surgery in his history. These other descriptions are useful to know though. Defective membrane protein resulting in reduced antibody class switching describes hyper IgM syndrome. if you have reduced antibody class switching, we don't have IgM B cells turning into, IgG, IgA. And so you have high IgM on immunoglobulin analysis and low levels of all of the others. Um, Defective phagosomal enzyme resulting in reduced reactive oxygen species. This is what I mentioned at the end, but wasn't on the slides. I need to update these. But this is the chronic granulomatous disease caused by defective oxidative burst, so defective neutrophil killing of those catalase positive bacteria. Um, Microtubule dysfunction is vague and doesn't refer to a specific um, immunodeficiency syndrome. Finally, the last one, enzyme defect resulting in impaired B lymphocyte maturation. That's also a good thing to know because it's a 7-year-old boy. And this is Bruton's A gamma globulinemia, which is a defect in the Bruton tyrosine kinase, which is an enzyme. Um, what was I going to say? Yeah, X-linked, so as in boys, but the other findings in this patient lead you more towards DiGeorge syndrome, which I appreciate wasn't on the slides. I'm really sorry about that. Um, but yeah, that's all for today. That's all of the questions. Um, as I mentioned, the questions are slightly harder than what you would get on LabMed. Some of them are taken from LabMed banks, some of the respiratory ones, but these ones are slightly harder than normal. But thank you for coming. Please do fill in the feedback form for the slides and I'll send them out today. Bye.